right, now we're starting. Welcome everybody and thank you for joining us today. I am Patricia Geli. I am the Executive Director of the Reform for Resilience Commission, working globally to support healthier and more sustainable economic growth. I'm also a research scientist here at the Global Health and Population Department at the Harvard Chan School of Public Health. It's a great honor to be here in the Harvard Chan studio together with our two distinguished guests. Ambassador Roman Macaya, who until recently was the executive president of the Costa Rican Social Security Agency, commonly referred to as a CAJA, which has a national mandate for all public health care services. He also previously served as the Costa Rican ambassador to the US, and he was a Menschel Fellow here at the Harvard Chan School of Public Health. And next to me we have Dr. Asaf Bitton, Executive Director of Ariadne Labs, which is a health systems innovation center at Brigham and Women's Hospital and Harvard Chan. Dr. Bitton is also an associate professor both at Harvard Chan and the medical school. So let's get started. I would like to kick off our conversation today by highlighting one statistic that I believe summarizes Costa Rica's incredible healthcare advances over the past decades. In the 1950s, the life expectancy in Costa Rica was 55 years. That's 13 years shorter than it was here in the US. Today, life expectancy is 81 years. And by contrast, in the US, it's 77 years and declining. So let's put that in another way. Since 1950s, life expectancy in Costa Rica went up by 26 years, and it went down by 4 years in the US, and it's still dropping. This is remarkable, especially since Costa Rica spends less than the US on healthcare and less than the world average. As a percentage of GDP, Costa Rica spends 8% compared to 18% in the US and 10% as a global average. Before we start talking about the reasons for this incredible progress, I would like to play a short video describing one of the key foundations of Costa Rica's healthcare system. I'm talking about the IBAIs, which are community-based primary healthcare centers serving the entire population. Here's how they do it.
Every week, community health workers in Costa Rica set off to make home visits with families all across the country, from remote mountainsides to the suburbs of San Jose. Home base for community health worker Ilber Zunigo is the Chinaquicha Ibais, one of Costa Rica's more than 1,000 community-based primary healthcare centers providing care to all of the country's nearly 5 million citizens. Run by Costa Rica's Caja Costarricense de Seguro Social, the IBAIS meets most of the health needs for families, from prenatal care, preventive screenings, and chronic disease management to wellness programs. When referrals are needed, the IBAIS teams coordinate care with specialists. Community health workers, known as ATAPs, also make an annual visit to each family in their homes to strengthen ties to the community and proactively assess their healthcare needs. More vulnerable patients who cannot easily travel get regular checkups.
Thank you. So, Ambassador Macaya, can you tell us more about this focus that we saw on prevention and primary care? What does it look like in practice and in the communities across the country?
Well, it's a pleasure to be here at the Chang studio and to be with you, Dr. Patricia Geli, and my good friend, Dr. Asaf Bitton, who knows a lot about the Costa Rican system. I'd like to highlight 2 points before I get into the specifics. One is that none of these results are an overnight phenomenon. It's the result of decades of investment, of expansion in infrastructure, in programs, in coverage, in medical training. And so it takes that sustained effort to get to where we are today. The second point is that Costa Rica has no army, and that's been the case since 1949. So what would have been a military budget was available for social spending, whether it's healthcare, education, and so forth, and that makes it more sustainable. Now, getting down to the coverage, this has all been structured by the Caja in a way that covers the entire country. The country is about the size of West Virginia. It's a small country, but it's divided into 7 health regions. Each health region is subdivided into health areas that have their own large clinic, that offer specialty care in some specialties, and each of these health areas have on average 10 EBAIS teams. These are teams of for primary care purposes that consist of a general practitioner, a nurse, a what we call an ATAP, which is a primary care technical assistant, and a medical records clerk. Now, the ATAP is an interesting figure in this team because he or she is a trained community health worker. They're embedded in the community, making house calls, following up on difficult cases, people that cannot come to a clinic, and receiving some level of care there at that level at home, whether it's vaccinations, whether it's follow-up on medications or chronic diseases. And the whole population that's covered by an EBAIS team is estimated at 4,500 people. That's the design of the system. And they are categorized into risk groups, with the highest risk group receiving on average 3 visits per year at home. And then you have the second tier receiving 2 visits and the first tier receiving 1 visit. So it's an outreach system that provides a level of education and care at home, but also it's the gateway into the healthcare system. So the EBAIS are the ones that see that patient for the first time, and then they are referred to secondary or tertiary care as needed.
Thank you, Ambassador Macaya. Dr. Bitton, your team at Ariadne Labs has been working with Costa Rica for quite some time. Clearly, the EBAIS system is a key driver of the country's success. From your perspective, what are some of the other factors?
Thanks for the question. It's really a pleasure to be here with both of you. You know, the impetus for our partnership with Costa Rica and our time together, or really over the last 7-8 years, started around the formation of a global consortium, a global network called the Primary Healthcare Performance Initiative, convened by Gates Foundation, World Bank, WHO, and other stakeholder partners. And one of the key parts of the initiative was really to try to understand where primary healthcare endeavors and initiatives were working. And it quickly became apparent that Costa Rica stood out in the ways that you described, but also it stood out in the fact that its successes were not really well documented outside of Latin America. It's well documented, of course, in Costa Rica, of course, in Spanish language literature, in English language literature, and in much of the health policy discourse at that time. Costa Rica was thought of as an interesting outlier, but mainly, to your earlier point, we would hear that's because they have no army, and there's a lot of social cohesion and good social spending, so it would just magically come together. My time in Costa Rica and talking to people, I love to, when I go to a country, to talk to primary care healthcare workers, and I talk to ATAPs and to folks in the EBAIS teams, and it just seemed that there was a layer of intentionality and organization and structure. And that was the impetus for digging into and asking from a point of curiosity. Yes, there are these contextual factors that are making it easier, but how have you actually, over these 30, 40, 50 years now, started from a series of reforms focused on maternal child health, focused on rural vaccination campaigns and WASH campaigns around hygiene, really classic community health worker structures into the 70s and 80s, again, rurally focused, that were working, they were showing results, but would make Costa Rica an interesting bright spot, but not quite the outlier that it is. And it's really when we started delving with you all, and I appreciate, you know, meeting with you and your teams when you were ambassador, and you graciously appreciated our inquiry here to try to understand and help the world understand what lessons were intentionally built, that we came to see the period of the 80s, even with you know, World Bank loans coming in and with different successive political parties on each side of the spectrum, there started to be this consensus built with the provider groupings and with the CAHA that an intentional focus on community-oriented, community-based primary healthcare for everybody in rural, but then urban, which is really hard, and for everybody, inclusive not just of citizens, but of migrants, of indigenous communities that are historically marginalized, and other communities, was a focus. And teasing apart that layer of intentional policy development, community engagement and building from the health areas on up, and a kind of universal expansion until Ebais had become, you know, available in every health area, was, I think, an amazing journey for us. And then we started to understand, and you helped us understand, that from an outside perspective, it wasn't just about universal coverage. It was about the data and monitoring infrastructure to maintain the ability to manage in real time layers of intentional data that were then, by the late 90s and into the 2000s, starting to be sequentially connected. By now, as of 5-6 years ago, a universal identification and health record structure, and then a fascinating set of management endeavors that, again, ensure the ability of a system to meet its equity and efficiency targets, and, as we'll talk about later, kind of upend the ways that I think we've seen in other systems, their approaches to equity. So it's been an amazing journey to learn with you and from you.
Thank you very much, Dr. Bitton. A question for you, Roman. One of the biggest challenges that we face here in the US are the large racial disparities. For instance, Black Americans have a life expectancy of less than 71 years compared to Asian Americans, which have 85 years. Are there similar disparities in Costa Rica based on ethnic group, income, or region?
Well, in Costa Rica, culturally, equity is a very important value in the system. So there's a lot of effort to try to achieve equity throughout the population, regardless of race, of income, of geography. And what we find is that sometimes there may be a geography that is lagging a little bit because of lack of infrastructure or perhaps resources, specialists and so forth in that region. And what we do to try to correct that situation is to assign more resources. In other words, to invest more in that community, which is usually geographically based. We don't see the longevity or the mortality gradients by income that you see in the US, at least not that steep. In fact, if there's any slant, it's the other way around. The lower quartile income group has a slightly longer life expectancy than the higher quartile group. And that comes down to the system. I mean, we eliminated the gradients due to income in infant mortality or maternal mortality and so forth. And so we start with the low-hanging fruit on where are the areas of impact that we can move the needle on, and then we move up from there. And so that has been a progressive expansion of the system and deepening of care that's available to the population. That's why I started by saying this is not an overnight phenomenon. It's been going on for 80 years or over 80 years that the CAHA has been in existence. So it's an interesting phenomenon, and there are very interesting characteristics of the aging in Costa Rica, which I don't think we have time to delve deep into. But Costa Rica is one of 5 countries that has a blue zone, where a lot of the population live well into their hundreds. And that blue zone in Costa Rica happens to be in a relatively poor area, just as an example that it's not correlated with income.
Very interesting. Thank you, Roman. Now I would like to shift gears to talk about the lessons learned from Costa Rica. So Costa Rica has made significant investments into primary care in an effort to maintain health and prevent disease, as opposed to focusing on expensive treatments for curing those who are already sick, as we do here in the US. So a question for you, Asaf. You run Ariadne Labs, which focuses on health systems innovation. And I'm curious about what you see as the biggest lessons that the US could learn from Costa Rica in terms of the way we organize, fund, and establish health priorities.
You know, though the two countries are so different, we've argued, and I think you've helped us learn, Roman and your colleagues, that there are some significant lessons. I think it starts first from a system orientation. I mean, the question at hand, it's a decade-long question. It's not. It cannot flip with one policymaker, or political party, or funding endeavor. But the question for U.S. local, state, regional, national policymaker is: do you want to build a sick care system, or do you want to build a health system? In the middle, you could build a health care system, but I would argue right now in the US, we have a sick care system. If you are acutely ill, if you are in need of high-tech, complex, procedurally mandated or based services in a hospital, and you have insurance, and you have the agency to navigate this healthcare system, you're in pretty good hands. You might argue, and certainly as a healthcare provider in the midst of the COVID pandemic, the US, if you have access and you have agency within the system, it's a pretty good place to get sick. It's not a very good place, to be frank, to be a consumer or a person trying to improve your health. We spend $4.5 trillion to get the outcomes that you talked about with shocking and shameful inequities. Doesn't seem to be a good value equation. So the Costa Rican example to me is one around first system orientation, and then the power of the logic of incrementalism, an incrementalism that spans political party and regional kind of classification. And it can't just be that, you know, a state or a health or a region takes on what is a nationwide one health, all of society endeavor. And then as you think about, as we kind of go down to more and more granular levels, what is the system orientation centered around primary health care, which is that intersecting point, not just between primary care as a clinical entity, you know, clinicians in four walls of a clinic, but really teams that feel the proactive responsibility for the care of a defined population, inclusive of everyone in that population, regardless of age, race, ethnicity, immigration status, and who see the relationship in the formation of health as one that's not, I'm going to wait for you to come to my clinic, but as Roman and colleagues have shown, we're going to go interact with you. We're going to find you, and hopefully you'll let us in the door, which they do, and we're going to reach out to first start with maternal child health, preventive vaccine kind of initiatives, but then move it toward non-communicable disease initiatives, the ability to interplay between medical care, nutrition, housing, transportation, and then to integrate that approach to health around this approach to populations and equity. It comes with trade-offs. We should talk about it. We're not trying to paint a picture of Costa Rica as the perfect system. We'll talk about maybe waiting lists and access to some specialty care or hospital-based care. But you can see the implications on a population level. And I think for us in the US, learning from that and applying it, starting at perhaps our federally qualified health center level, the 11% of people in the U.S. taken care of by federally qualified community health centers that are teams of providers that have the initial early integration of public health and health care and are community oriented with community advisory boards. There's actually a lot of homology there, and it's a good place to start. And then we talk about payment policy and expanding the part of the healthcare dollar that we are actually aiming at creating health and not just chasing sickness.
Thank you very much. So another unique feature of Costa Rica's healthcare system is that it offers home checkup visits, even in the most remote areas that are difficult to reach. And I would like to show another clip.
The Etaps crisscross the sometimes rugged tropical terrain on motorcycles, ATVs, and trucks to get their patients. Today, Hilbert is visiting the Obando family on a mountainside in an indigenous region of Costa Rica. Here, he will do a health check-in with Tamara and her son Jaime, checking vital signs and medications and keeping little Jaime on track with his vaccines. And he will take extra time with Tamara's brother Ever, who has cerebral palsy and is unable to travel regularly to the local Ibais clinic. Hilbert logs everything in the family's electronic medical record using a mobile device and makes note of his visit on the Etap visit log in the home. The electronic records can easily be reviewed by the rest of the Ibais team back in the clinic. This remarkable investment in community-based primary health care is one of the ways Costa Rica has created one of the best health systems in the world, with nearly universal health coverage, lower costs, and better health outcomes.
So, Roman, as we have just seen, a key to Costa Rica's success is the electronic data system, which can integrate data on household needs, local conditions, and medical records. Can you talk about what kind of data you collect and how you use it to improve public health?
Yes, this is an interesting story about the Costa Rican healthcare system, is that there is an integrated electronic medical records system. The implementation of this system was finalized in September of 2018. And it connects all health centers, whether they're Ibais teams, all the way up to tertiary care, and throughout the geography of Costa Rica. Now, reaching every point of Costa Rica is no easy task because there are some very remote, difficult to access locations. Some places you can only access with a helicopter. And yet those Ibais teams, and specifically that ATAP, that primary care technical assistant that's knocking on a door, first he or she knows where to go, because now about 65% of all households in Costa Rica are georeferenced. And this is all contained in our electronic record system that's on a tablet, and it has all kinds of information, from social economic information of what is that household like, what type of floor does it have, is it a dirt floor, is it a finished floor, how do they cook, is it a wood burning stove, or is it gas or electric, and so forth. And of course, who lives there, and what are their health issues? Are there chronic diseases in the house? Which members of the house? Are there children? Are their vaccination records up to date? So when an ATAP knocks on your door, it's not just an ATAP, it's an ATAP who comes with a lot of information. That person might know more about the vaccination record of your children than the parents. And so it's a very powerful tool to bring into the system that not only brings information to bear on the primary care setting, but also collects information. So there's updates and there's medications that are prescribed and have to be recorded. So every day this database of information is growing, and we are learning how to use it better and better for administrative purposes, but also to improve care for people throughout the country.
Thank you, Roman. Any reflections from your side, Asaf?
I mean, general awe and open mouth. Look, as a person who's been working, through Ariadne and on the front lines, seeing the integration of an electronic health record, even in a partial system in one city, and how difficult and expensive it is, and it's still fragmented, it makes one incredibly humble about the task at hand, that you all have successfully carried out. The awe part of it is, the last visit we were in Costa Rica right before the start of the COVID pandemic. Dr. Maddie Pesic, Dr. Dan Schwartz, and we did a post-hospitalization discharge visit with an Abais team in an area near San Jose, very poor area. It was a woman who had had a stroke, and she was a Nicaraguan migrant. And they took out the tablet that geo-referenced this house. And so it's like, don't put a PowerPoint. Let's show you how it works. And it had all her information, including her discharge medications. And it had information about the structure of the house. And then I'll never forget this, because we literally stopped in the middle of the street. It said in Spanish, please make sure that you knock on the back door and go into the back door once they let you in and not the front door, because there is a dog that can be a little bit mean at the front door, so you might get bitten. And I'm thinking, I got faxes in my office, from other clinicians, and this record is telling me not to knock on, get bitten by a dog. So I continue to be very impressed.
But maybe to add a little point there is that there's a lot of information not just about the household that's being visited, but the community around that household. So if the system highlights that there's a neighbor that's about to be visited or has to go to the clinic, or there's some medications that are going to be delivered here, maybe we can take advantage of that trip and bring in some other medications for this household. So you get a view of the community, not just the household, and that allows for greater efficiencies in care, but also more information should mean better care if it's used appropriately.
That's fascinating. Do we have anything similar in the U.S.?
I always say that in the U.S. we have every kind of health system and every kind of health financing mechanism. It's just not widely distributed. So, people they say, oh, no, what are you talking about? We don't have socialized medicine. Oh, we do. It's called the Veterans Administration, and it's a national system with one unified record and home-based care. Is it as good? No, but its outcomes are quite strong. We have every other kind of system, including from concierge care to different forms of financing and different forms of accountable organization. We talked about federally qualified health centers as a locus, because they're one of the few parts, and this is again one of the central lessons from Costa Rica, is the extent to which the public health functions are merged or at least integrated on a data platform with medical care functions. I think we're starting to see that. Some of the most forward-thinking accountable care organizations who've realized that you can't really care for populations if they are food insecure or suffer from interpersonal violence or have housing issues. They are recognizing that, but I think there are challenges. Of course, we don't have the social cohesion and trust to, quite frankly, in most communities allow geo-referencing and community health workers to knock at the door. I think there would be some safety concerns in many parts of the country in terms of, quite frankly, the extent to which guns are available in the U.S. And the trust that has been lost or maybe was never there for appropriate reasons between many communities and the healthcare system. So I think the way, how long it takes trust to be built up and how quickly it can be lost is a big central lesson. I also really, think about the ways in which, data is managed and organized, and the zeal and that my observation directly that so many health managers and Abais teams have for using and looking at their own data, and really directly interplaying that into what changes next week about the approach. I think we can, as U.S. primary care teams are moving more to become increasingly teams that aren't just responsible for visit volume and more about populations, I think stopping the visits on a Wednesday afternoon so that you can run through your panel, be more home engaged. And the last lesson, I think this is way beyond the US, but also to across the world. The evidence base is very clear that professionally trained and remunerated community health workers produce better outcomes. There's not much real scholarly debate. There's implementation and financing challenges around that. And I think the Costa Rican example reminds me again the power of well-trained and well-managed community health workers to implement in a wide array of services effectively.
Thank you for the rich conversation. I can just imagine all the opposition that this kind of program that Costa Rica has would draw in the US. Roman, could you talk about the political dynamics in Costa Rica? What challenges did you face in maintaining universal health coverage, and how did you overcome them?
Well, it's a good question, but it's a different context. I think in Costa Rica there's been a fair amount of consensus around the value of a universal healthcare system. It wasn't always aimed at being universal. When the Caja was created in an agreement in 1941, it was not a universal system. It was designed to cover only workers, and then it was expanded in steps to workers' families, and then the unemployed, and then the poor, and finally immigrants, and so forth. And there was a stage where we declared universal coverage as a goal of the system, but no one has really ever contested that. So the term socialized medicine has different connotations in different countries. In Costa Rica, socialized medicine is a good thing. It is something to be proud of. It's part of our population health. It's part of our safety net. And so there might be political discussions on, different speeds of implementation, and, but it's really getting to where we want to get as fast as possible. Now, that doesn't mean that there's consensus about everything. There's obviously, we're in a democracy, and democracies can be messy. But I would say that the growth in coverage and the strengthening of the Caja has been one of the very few policies of state that has endured throughout over 80 years of existence of the Caja.
Thank you. Asaf, are you hopeful that we in the US can make strides in the same direction as Costa Rica, as we have just heard? Why or why not?
I think of comparative health systems discussions like this as about directions and not recipes. So I think the opportunity for the US is not to try to recapitulate or have a cookbook on Costa Rica, but the opportunity is to take these lessons and directions and ask ourselves, how can we inflect it into what seems to be a broken system and a tied up process? And what I think the Costa Rican example offers beyond the lessons of incrementalism is how we can think about, seeing the macro trends here in the US. The Affordable Care Act, as partial as it was, has survived now over a decade. It ensconced the principle of expanded coverage, and in practice actually covered a lot more people. Not enough, but a lot more people. It also proved a very salient political point that I think Roman was getting at, which is that once you expand coverage, you start to also change norms, and it becomes very difficult, even from the polarities of the political extremes, to take back that coverage and take back those gains. And then we match those with secular trends. Like, for instance, this past year or last year or 2 years ago, the majority of kids in the US are now covered under Medicaid, which is the state federal policy for low income and other forms of necessary coverage. The majority of healthcare expenditures as a payer is the US government, between its payments for Medicare for the elderly, Medicaid for the poor and disabled, and the VA. For like it or not, as a country, we're moving toward having larger and larger parts of healthcare payment be adjudicated or at least run through parts of the government. And that gives us opportunities to both think about how to most effectively use that, but also how to change the dynamics of and ask ourselves in eras of budget, necessary budget reckoning, can we spend more, and should we want to spend more on primary health care, which we can. We only spend about 5% right now. We could bump it up to 10%, and some states have actually mandated that. And that gives us, and then we start to say, what would we do with that spending? And we've talked about kind of some of the systems we would build. So I wouldn't lose faith, even though there's a lot to be cynical about.
Thank you, Asaf. Before we end the program, I would like to turn to COVID. The pandemic revealed many long-standing issues already present in the healthcare systems across the world. And once again, Costa Rica's initial response to COVID has been praised by many international experts and observers. So Roman, I wanted to ask you if you could walk us through the country's response to COVID. And how were you able to leverage your universal healthcare system during the pandemic?
Well, that's a big question. We could have spent an hour on this, but a pandemic is obviously a big challenge for any healthcare system. And we had to very early take stock at what were our challenges or our weaknesses and where was our edge or our strengths. One of our challenges was Costa Rica actually does not have a large number of hospital beds per capita. It's about 1.1 for every 1,000 people. That, if you look at OECD countries, is at the very low end. And there are countries that have 5, 10, even 12 times more hospital beds per capita. So we needed to first learn fast about how to deal with this and the pandemic itself, learn about this new enemy, and buy time. We needed to build up or prepare infrastructure, get ourselves ready, and it wasn't going to be the same to have a peak caseload early on than later. Time mattered. So we started out by trying to learn fast. We learned from anyone that we could learn from. So we started out by arranging several teleconferences with the Chinese health authorities to find out early on in 2020 what were they experiencing, how were they dealing with this, what was working, what wasn't working. Obviously with many other countries as well. And we started to communicate with the general population on a daily basis what we were learning, how to protect yourself, how to protect your family. These were televised press conferences. They were widely watched on a daily basis. Everyone was very nervous. And we had to try to avoid a peak in exponential growth in cases. We were looking at what was happening in Madrid, Spain, in northern Italy, where strong socialized healthcare systems were being saturated. And that was very scary. So we looked at what are our strengths. Well, our strengths were we have a single system. It's not fragmented. It's an entirely integrated system. So we could make decisions such as this hospital or the wing of this hospital next week is going to be COVID only. And these other hospitals are going to support this hospital dealing with the patients that would have been treated there. Those discussions could take place in a meeting, and the decision could be made in a meeting without entering into who's going to pay for what, whose budget are we touching, because it's all under one umbrella. So that was one big strength. Another strength was the electronic medical record system, which was already implemented in 2018, fortunately. Because when we started to reach saturation levels in May of 2021, we had to start transferring patients and finding beds throughout the system wherever they were available. And fortunately, we didn't have to have this follow-up logistics of how do we get the medical records to where that patient is going. The paper didn't have to follow the patient. Wherever that patient ended up, we could open up his or her medical record. So the medical record was an unsung hero of the pandemic response. And then the autonomy of the Caja. the Caja defines its own budget, it approves its own budget, it even defines the payroll contributions that finance the system. Those are not defined by Congress. They are defined by the board of directors of the Caja. I think it's the only system in the world that has this authority. So we could increase resources as needed. And so all this integration, this informatic integration, and the budgetary autonomy allowed us flexibility that resulted in comparatively relatively strong performance in the pandemic.
Thank you very much, Roman. Asaf, let me turn to you. How would you say that this compares to our response in the US?
Pretty different. Speaking as a healthcare worker, I mean, we don't have probably time to relate that sordid story, but look, I mean, we basically had very few of those features that Roman just talked about. We didn't have clear communication. We didn't have a unified record, no whole of government. We had elements within the government that were questioning the veracity of the existence of this, the science around it, the need for a unified approach, all those things. I mean, many people lived through it. I would say that the difference between the systems and what was really highlighted, we really leaned, and I remember this very clearly, we leaned on the excellence and depth of our acute care system. And it performed admirably. And people did heroic things. I mean, I really hope that, I know that nobody has on their lawn signs, healthcare heroes, all that, but I saw things that were inspirational. We saw a lot of death, unnecessary death. We saw inequitable death. It was very traumatic. And I think people in the US do not know how close there were parts that we came to. We were barely holding on in Boston. Maybe April, May, we were running down to the last few ICU beds. Our primary care clinics were urgent care centers that were sometimes ERs. I mean, it was insane. But we leaned on the acute care system when we shouldn't have, if we had had better leadership around and unified messaging. And then we did something else that was very American. We put massive amounts of money into an innovation and biotech structure that produced, with partners around the globe, based on 30 years of research, that was federally funded and funded from across the globe, an unbelievable set of vaccines in record time, and then had a lot of trouble distributing them, and then trust and all that. So it's just such a very I think it embodies many of the values and structures of our healthcare system, both good and bad. Very different than the Costa Rican example in some respects.
Yeah, thank you very much, Asaf. Roman, Costa Rica was one of the first countries in the world to receive vaccines. How did your experience as ambassador come into play? And what was the key to success in distribution of vaccines?
Well, my background as an ambassador really didn't come into play in this. What came into play was the scientific team that evaluated which vaccines we should be betting on. And I say betting on because we were in discussions with the pharmaceutical industry way before these were approved. And we had to start based on what was known from the early clinical trials. These were not approved vaccines, where we were going to commit to say, okay, we're going to commit to this volume of vaccines from this manufacturer. That's a tricky yet, because until it gets that FDA approval, you don't know if that's actually going to become a product. As Asaf mentioned, these turned out to be incredibly good vaccines at preventing severe cases. But it was that scientific team that really pointed the way, and I would say very, now in retrospect, very accurately as to where we should focus our efforts at procurement of vaccines early on, because we knew the whole world was going to be in line, and we got in line very early. So we were actually the 7th country in the world to start getting vaccines. What did, where diplomacy at a country level did come into play was in donations of vaccines from countries that had greater levels of vaccine hesitancy and were going to face expirations of vaccines. They started to look for countries that could really implement vaccination programs to take advantage of what they were going to essentially throw away. And so that's where I would say diplomacy at a country level, the Ministry of Foreign Affairs, had a tremendous role in this.
Thank you very much, Roman and Asaf. Clearly, there's a lot the U.S. and other countries can learn from Costa Rica. And I would like to emphasize one thing in particular, which is that health equity really is key. By investing heavily in preventive and primary care and making healthcare services more accessible to low-income individuals, everyone is better off. And as we saw from the pandemic, viruses do not respect borders. So universal healthcare is key to build more resilient societies. And on that note, I want to thank you all for joining us in studio and online. And if you missed any part of this conversation, you can go to our Harvard Chance YouTube channel and see it there. Once again, thank you everyone, and a special thanks to our guest ambassador, Roman Macaya, and Dr. Asaf Bitton. Good afternoon.